Assalamu alaikum. Welcome to the 9th session of HIV Awareness, Prevention and Education Project in Pakistan, designed and led by APPNA-MERIT HIV Committee. Our project aims to reduce HIV stigma, increase HIV awareness, and increase knowledge about the disease among the healthcare providers and communities in Pakistan using educational and research tools. Please note that this is a volunteer academic activity and all views expressed here are speakers' personal views and they are not representing institutions. Our moderator today is Dr. Hina Javed. Dr. Hina Javed is an assistant professor in family medicine at University of Health Sciences, Lahore, Pakistan. Her areas of interest include promoting awareness about primary care needs, training of medical officers for primary care, antibody stewardships, injection safety, managing telemedicine, center during COVID-19, raising public awareness about chronic diseases through newspaper articles. So here you go, Dr. Hina Javed. Thank you very much.
Thank you very much for asking me to moderate today's session, and I'll introduce the speakers. Our first speaker today is Dr. Philip Chan, MD, MS. He's an associate professor in the Department of Medicine and School of Public Health at Brown University, and he's an infectious diseases physician. Dr. Chan is also a medical consultant in the Division of STD Prevention at the Center of Disease Control USA. He's the director of the Miriam Hospital STI Clinic, consulting medical director with the Center of HIV/AIDS, Viral Hepatitis, STD, and TB at the Department of Health, Rhode Island. He has a long list of other academic and clinical accomplishments, which are hard to summarize in a few minutes. In summary, he's an accomplished professional. And if you want to read more about him, you can visit the Brown University, where you can see his profile. So without further ado, I'll hand over to Dr. Chan. Thank you for joining us.
Great, thank you so much. And thank you everyone for joining today. So I will say it's good timing to talk about STIs actually. So here in the US, our CDC just published our 2021 updated treatment guidelines, which came out last month. So it's really good timing. For the CDC's STI treatment guidelines, I would refer people there for the US-based standard in terms of treating STIs. It's really the accumulation of all the experts in the US. It's taken years actually for it to come together, but it's really a summary of all the best evidence and at least what we do here in the US in terms of STI treatment. And so I want to be sensitive, of course, that what we do in the US, not all of it is going to apply in other places throughout the world, including Pakistan. But I'm happy to answer any specific questions, and hopefully I'll talk about the US experience, and hopefully there's some lessons that you could apply, certainly in Pakistan and your clinical practice. So the first thing I'd like to talk about is just how we think about STI prevention. So I love preventative medicine, I love public health, and I love preventing HIV and STIs. And when I think about and counsel patients, importantly, about STIs, I generally look at this puzzle piece diagram on the left here. And what this illustrates is really all the ways that one can protect themselves, right, from HIV STIs. So the first off is just routine testing of HIV, of STIs, can go a long way to early identification and treatment of HIV and STIs. So just testing is a win. Of course, condoms, viral suppression if someone is HIV positive, pre-exposure prophylaxis and post-exposure prophylaxis. We won't talk about that much today. I will say that there's another US set of guidelines looking at PrEP and PEP. The STI guidelines certainly talk a lot about PrEP and PEP, and we'll save that for another time. Circumcision, male circumcision of the penis is certainly a way to prevent HIV and STIs. Talking to partners, making sure people have, counseling people that certainly being monogamous, abstaining from sex in the right situations, and making sure that their partners were tested for HIV and STIs is a good way to reduce your risk of those as well. And finally, there's a lot of places, a lot of people working on microbicides and vaccines. Microbicides, formulations, different gels that have some antibacterial properties to prevent STIs. One thing that we're trying to do our best here in the US is to really encourage our clinicians, physicians, providers to take a sexual history. So that in thinking about preventing HIV, STIs, and really understanding and making an accurate clinical diagnosis, taking a robust and accurate clinical sexual history is really important. And so what our CDC recommends is certainly this 5P approach, talking about partners, practices, protection, i.e. condoms, past history, and certainly pregnancy. The other thing in thinking about prevention is certainly vaccination. So here in the US, we very aggressively vaccinate people. It's a strong recommendation, and most kids, children, and adolescents are vaccinated for hepatitis A and hepatitis B virus. We also now have started over the last few years really being aggressive about vaccination for HPV. It's recommended to be routine at age 11 to 12. As many of you may know, HPV vaccine, HPV in general, is a very common cause of cervical cancer, but we're also recognizing it as a major cause of other types of cancer, anal cancer, head, neck, and throat cancer, etc. So we're really in the US pushing strongly HPV vaccine, and we know that it's most effective before the onset of sexual activity. And that's why we really try to give it the earlier, the better. And here in the US, 11 to 12 years of age, but we give it all the way up to 9 to 26 years of age in individuals. So let's talk about just some screening. I'm going to go over this very briefly, but here in the US, we have a very strong recommendation for especially young sexually active females, age less than 25. And that's because, as many of you may know, we see a lot of complications and sequelae in young women, specifically ectopic pregnancy, pelvic inflammatory disease, infertility, chronic pelvic pain. So we try to get a handle on that by asymptomatic routine screening, especially for young women under the age of 25. One direction here in the US that we're moving towards is focusing also and looking more at extragenital testing. And so one thing that we've realized over time is that if you check, the most common testing rate for gonorrhea and chlamydia is NAT testing, nucleic acid amplification testing of a urine specimen, PCR-based testing. And what we've seen here is that if you only check a urine specimen, especially in gay and bisexual men, is that you're missing gonorrhea and chlamydia infection potentially of the throat or rectum, where you can have gonorrhea specifically, especially, but also chlamydia. And that may be missed if you do urine-based testing alone. And so at least here in the US, there's a movement towards doing 3-site gonorrhea chlamydia testing, especially highly recommended for gay and bisexual men because of the sexual activities there, but also for younger women as well. So it's one thing I'll highlight a little bit more over the next slides here. But I think what we've realized is, and many of you may know, is that having any STI really increases your risk of acquiring HIV infection 3 to 5-fold. And that's because when you have gonorrhea or chlamydia or syphilis or herpes, is that you have breaks in the skin, the epithelial lining, and that just allows HIV to enter more easily. When you have an STD, it also recruits, right, the CD4 cells, the immune cells, which are the very targets of HIV infection itself. And there's been some good modeling studies, one based out of the US here, that showed that at least 10% of all new HIV infections may be due to having gonorrhea or chlamydia infection alone. And so for that reason, and I know this varies a little bit across the world, but here in the US, we are seeing 70%, upwards of 70% of our new HIV infections among gay, bisexual, and other men who have sex with men. And therefore, we very aggressively screen gay and bisexual men, MSM, for STIs as well as HIV. And so for an individual, a gentleman who's having sex with other men, we generally try to screen them every 3 to 6 months if they're having multiple partners. There's good data now that if you do not do extragenital testing, that you may be missing up to 70% of gonorrhea and chlamydia infections, especially, and especially in gay and bisexual men. This was a study published here in the US in 2014. We've also done data at our own local clinic here in the state of Rhode Island in the US. And we've all observed that you really are missing a lot of gonorrhea infections specifically and chlamydia infections if you are only testing for urine. The other thing to mention is that there's good data now that self-collected swabs are okay, and they're good, and they're validated. And our CDC does say that that is okay. And basically what we do in our clinic settings, most of our clinic settings, is we let people self-swab their throat and self-swab their rectum for gonorrhea and chlamydia. And it's been validated now across multiple studies that that's okay, and that it's equivalent to having a clinician or a clinical staff collect the specimen. In terms of HIV recommendations, here in the United States, it's recommended to screen all people once, 15 to 65 years of age. We've tried to reduce the stigma, the shame, some of the barriers associated with HIV testing. And one of the ways that we've tried to do that in the US is to really make it part of routine medical care. And so we do strongly recommend that people get opt-out HIV testing, meaning in the US is that if you come in for a wellness exam, a primary care visit, a general checkup, is that you should be offered at least once HIV testing, and more frequently, potentially annually, if you have ongoing risk infection. The test of choice before we leave HIV is going to be an antigen antibody test, our 4th generation test. It really is the best test that we have for HIV. It's very accurate. It detects a number of acute HIV with the antigen component of the antigen antibody, so I strongly do recommend that. So let's move on a little bit to some of the other classic STIs. And again, I'm going to give an update about that's based on the CDC's, the US CDC STI treatment guidelines. Again, this is really a summary of the latest evidence and based on also expert opinion about updates for these STIs. The first STI I want to talk about is syphilis. So syphilis, I know is common, including in Pakistan. And the thing I want to focus on to start is just neurological syphilis, neurosyphilis. And I want to make the point that syphilis can infect the central nervous system at any stage of infection. And, you know, for a lot of us, syphilis, we have not observed a lot of syphilis in the past until the last decade. So in the previous decade, in the early 2000s, we really hit a low point of syphilis. But since the 2000s, we've seen a large increase in syphilis really across the world. And with that, we've seen a lot of the manifestations, including neurological syphilis and a lot of the other. So the first point I want to make is that we are seeing more ocular syphilis and otosyphilis. So syphilis associated with tinnitus, vertigo, hearing loss. Both ocular and otosyphilis can really result in permanent hearing loss. The historic evaluation and diagnosis of syphilis has been dark field examination. However, at least in the US, that's really had limited availability, and we test through serology, and that includes both the non-treponemal and the treponemal test. And you can see that here. Historically, the first test for syphilis, right, is an RPR or a VDRL, that is a non-treponemal test. Those tests are really non-specific, and they're looking for damaged cells, and they're binding to some of the lipoidal antigens within these damaged cells. They're non-specific. You can see false positives with other infections, like HIV actually, like other autoimmune conditions, and certainly in pregnancy and older age. We can also see occasionally false positive RPRs after vaccinations Interestingly, we can also see false positive HIV tests after vaccinations. It's been described with influenza. We've also seen it rarely with COVID tests, where you overly stimulate the immune system. But with syphilis, you can see a false positive RPR or VDRL in a number of medical conditions. That is why it's recommended to be confirmed by a treponemal test, and many times it's confirmed by the treponemal pallidum particle agglutination test, the TPPA. The TPPA has been shown to be one of the most specific tests for treponema pallidum, the cause of syphilis, and it's a very good test. Depending where you work, a number of hospital systems and larger labs are switching to the so-called reverse sequence testing algorithm. And what that means is, due to the cost and in the lab, the way that the high throughput labs can do, is that they're testing now with a treponemal test first. And the key of the treponemal test, right, is that once it's positive, it's always going to be positive. And so that's really the key piece of history that you want to get from someone who has any positive test, frankly, is whether or not they've had syphilis in the past and whether or not they've been appropriately treated. And in the case where you're using a treponemal test first, a positive treponemal test can mean, of course, that the person has active infectious syphilis, or it could also mean that they had syphilis in the past and they were treated. And so if you have a treponemal test, you want to get that piece of history. That's critical. And then you want to check a non-treponemal test. And so the RPR, the VDRL tests come back in titers. The titers do reflect the amount of disease activity, meaning a very high dilution titer, say of 1 to 256, 512, reflects very potentially active disease, high level, high burden of infection, versus a lower titer, 1 to 1, 1 to 2, 1 to 4, which generally reflects very low level disease. In the case where you lead with a treponemal test followed by a non-treponemal test, this reverse algorithm, if the treponemal test is positive and the non-treponemal test is negative, then we do reflex to a tiebreaker, a third test. In this case, it's recommended to use a TPPA test. If that's positive, you have 2 out of 3 tests positive, so you want to treat the person. If it's negative, then the initial treponemal test was likely a false positive. So these algorithms can be a bit confusing for sure, but as many of you know, syphilis is difficult to culture. We actually don't have great diagnosis for syphilis, which is why we use these indirect measurements of syphilis. In general, we follow the RPR or the VDRL titers. You really want to see a 4-fold change in those titers to tell if someone is appropriately treated. You also really want to make sure that you use a VDRL, the same testing method, either a VDRL or RPR, to look at these titer changes, because there is some variation across labs. Importantly, though, we do note that a number of people, even though they're appropriately treated, don't decrease 4-fold with their VDRL or RPR. And sometimes you have to use your clinical discretion, your clinical judgment, because in up to a quarter of people, you may not have an appropriate decrease. And the question always becomes, well, how do you tell if someone with syphilis is really cured? And the answer is you have to take a very careful clinical history. You have to make sure they don't have neurosyphilis, because if they have neurosyphilis, the treatments, which we'll talk about next, the intramuscular injections may not penetrate, and they don't penetrate well the CNS, and you may have failure. Alternatively, we also see people reinfected all the time, so it's difficult to tell. Resistance to penicillin of treponema organism is pretty much non-existent. So resistance itself is not necessarily a concern. In thinking about neurosyphilis, which is potentially one of the biggest complications of syphilis, it is recommended to do a CSF evaluation, a lumbar puncture, for anyone that has any signs or symptoms of neurosyphilis. And that could include, of course, any cranial nerve deficits, neurological functions. One thing that's changed, at least here in the US as of last month, is that it's no longer recommended to get a CSF examination if you have isolated, and I highlight that word, isolated ocular and otosyphilis. So if you have ocular, just vision changes, just hearing problems, what the data, the studies have shown is that the CSF examination is unnecessary because it's likely to be normal. So we would recommend just going ahead and treating for neurosyphilis, understanding that both ocular and otosyphilis are manifestations of neurosyphilis. And we'll talk about the treatment on the next slide here. The diagnosis of neurosyphilis, when you look at the CSF examination, is based on either an elevated cell count or a protein. And so if you look at studies in people with neurosyphilis, sometimes it can be very mild abnormalities, meaning the protein could be elevated, a minor elevation, or even a minor elevation in cell count. You can check a CSF BDRL. It's highly specific, meaning if it's positive, you have your diagnosis. But if it's negative, it doesn't rule it out. And in fact, it's only about 50% sensitive, meaning if it's negative, you still have a chance that the person could have it. In terms of pregnant women, I just want to mention that we do aggressively recommend that syphilis should be tested for all pregnant women. We do so here in the US at their first visit. If people are at higher risk, we do test later on in the third trimester. In terms of treatment, the treatment for early syphilis, when you think about treatment for syphilis, it's generally recommended you think about early syphilis versus late versus neurosyphilis. So early syphilis encompasses primary, secondary, and early latent syphilis, which is essentially meaning you've had syphilis for less than a year. If you've had syphilis for less than a year, you want to give 1 shot of benzathine penicillin, 2.4 million units once. If you've had late syphilis, so syphilis for more than a year, you want to give 1 shot of benzathine penicillin once a week for 3 weeks. A lot of times you may not know. A lot of times people have not had prior testing. If that's the case, you really defer and give them late treatment. The key is to distinguish between neurosyphilis when you want to give 3.4 million units of IV penicillin G every 3 to 4 hours, every 4 hours for a total of 24 million units every 10 to 14 days. And it's really key to distinguish between neurosyphilis and other forms of syphilis because the intramuscular formulations do not readily penetrate the blood-brain barrier. And so if someone has neurosyphilis, they will likely not be cured if you give them the intramuscular injection. So that's the important clinical reasoning to really distinguish between that. I'm going to quickly cover, I do know I have limited time here in the next 10 or 15 minutes. So I'm going to go through some of these slides a little bit faster just to make sure I highlight a number of these different STIs. I will mention alternative syphilis treatments if you do not have penicillin available or if someone has an allergic reaction, is you can use doxycycline. You use doxycycline for both early and latent syphilis. For neurosyphilis, there is limited data, but you can try ceftriaxone, 1 to 2 grams IV for 10 to 14 days. In pregnant women in the US, we still aggressively desensitize pregnant women with syphilis to penicillin. Penicillin, without a doubt, is the best treatment for syphilis. After you've treated someone for syphilis, you do want to follow up. Follow-up does depend on their stage of syphilis and whether or not they are HIV positive. If they have early syphilis, you do want to check, pretty much if they are HIV negative, you want to check at 6, 12, 24 months. If you do see a 4-fold decrease in titers, then they're cured. If you do not, you want to take a careful history, make sure they don't have neurological disease. You can consider retreating them, of course, but a lot of times you can just observe them and consider them cured. There's not a good way to test that people are truly cured, unfortunately, from syphilis if you don't have that 4-fold titer decrease. In HIV positive people, you do want to be a little bit more aggressive and check RPRs or VDRLs every 3 months for up to 24 months. Let's talk about chlamydia for a second. There's been some big updates in chlamydia here in the US. At least, as I mentioned, you do want to screen young women because of the complications there. And one big change that we saw here in the US as of last month is we're now going to be really pushing and recommending doxycycline 100 milligrams twice a day for 7 days. Previously, what we used to do is really push the azithromycin 1 gram orally once. And I do want to say, I'm going to show data on the next slide about this, but I do want to really highlight the azithromycin. If you have concerns about adherence, concerns that someone's going to pick up the medication or not be able to take 7 days of doxycycline, you should really use azithromycin 1 gram once. What's happened though, and I'm not going to read through this slide word for word, but what the data has now shown over the last few years is that doxycycline really is superior to azithromycin in terms of treating chlamydia. And one thing that we've looked at here in the US is especially among rectal chlamydia infection. And of course, gay and bisexual men, other MSM who are having receptive anal sex tend to be at higher risk of rectal infections. But the other thing that the data, the science has shown us is that even in women who have never had rectal sex, is that there's some cross-contamination between the vagina as well as the rectum. And so a significant number of women will have both urogenital chlamydia infection as well as rectal infection, even though they've never had rectal sex, because the vagina, of course, is close to the rectum and you get some cross-contamination. So for all these reasons, and for these recent studies over the last few years, doxycycline is now going to be recommended in the US. I will say that the absolute increased effectiveness of doxycycline is not that big. So you can see the first bullet point here, between 3 to 7%. So it's significant, but it's not large. And that's why, again, I'm kind of mentioning that if there's any concern about adherence or picking up the medication itself, is that azithromycin is still a reasonable alternative. The other thing I'll mention is that if you are using NAT testing, is to make sure not to test too soon. Interestingly, we've also seen this in COVID, but basically if you do these PCR tests, including a NAT chlamydia test within a week or two of someone who's been cured of chlamydia, treated and cured, is that you may still have a positive test because these PCR tests are picking up dead fragments. Interestingly, we've also seen that with the COVID PCR testing, which is why in the US, it's not recommended necessarily to test a test of cure in most cases. I also want to mention LGV, lymphogranuloma venereum. This is caused by certain subtypes, serovars of chlamydia trachomatis, specifically L1, L2, L3. And the key point here is that these tend to be more aggressive, and we see them a bunch across the world causing especially proctitis, including potentially mucoid or hemorrhagic rectal discharge. And I think importantly, certainly if untreated or complications of, can include colorectal fistulas and strictures. So it's important to make this diagnosis, and the key is that treatment is doxycycline for 21 days. So you have to treat longer, and I would specifically use doxycycline in a case of suspected LGV. I will say here in the US, we do not differentiate the different, in general, usually, we do not differentiate the different serovars of chlamydia. And a lot of times LGV is a clinical diagnosis here in the US, and we just empirically treat with doxycycline for 21 days. In terms of gonorrhea, the new guidelines updated this past year show that we're really recommending here in the US ceftriaxone 500 milligrams intramuscular once as monotherapy. And so I'm not sure what the clinical practice was in Pakistan, but in the US previously, we were actually doing dual treatment for gonorrhea because of the concerns worldwide of resistance. So in the US, prior to 2021, it was actually recommended to do ceftriaxone and azithromycin or doxycycline. And the azithromycin and doxycycline were actually recommended for everyone with gonorrhea because of the concern for resistance. Now, on the flip side, there's also the benefit that if you had someone with urethritis or cervicitis, the azithromycin and doxycycline would, of course, cure those infections as well. But what we've seen here in the US and across the world is that treating gonorrhea with two drugs really didn't do much, and in fact just led to more resistance, and we saw azithromycin resistance specifically in gonorrhea start to increase. So at the current time, the recommendations for gonorrhea treatment here in the US are 500 milligrams of intramuscular ceftriaxone once. If you're worried, if someone's coming in with urethritis, cervicitis, and you're going to treat empirically, it is recommended first to do the doxycycline if you can. If you can't or have concerns about adherence, etc., then you can do azithromycin 1 gram once. We do have some alternative medication regimens if someone's allergic or they don't have ceftriaxone. We are using gentamicin intramuscular once plus azithromycin 2 grams once to treat someone. Note the 2 gram dosing of azithromycin is relatively large, but it's recommended to go with gentamicin. And there's good data that this is a reasonable regimen, although people tend to have more side effects. You could also use cefixime, 800 milligrams PO once, as an alternative that's available in some places, but cefixime is the other drug that we're using to treat gonorrhea, although we still recommend the ceftriaxone first. I'm going to skip some of this just in the interest of time. The other STI I want to mention specifically is Mycoplasma genitalium. So this is an up-and-coming STI. It was first identified in the 1980s. It is a common cause of urethritis and cervicitis. There are some associations of varying degrees with complications, especially in young women, thinking about PID, labor, delivery, pregnancy outcomes. But they're not incredibly strong associations. And so we're still learning and doing data and doing studies and collecting data about Mycoplasma genitalium. I think the key points is that it's difficult to culture, takes like months to grow, and it's generally being diagnosed in many parts of the world with PCR-based testing, with NAT, similar to gonorrhea and chlamydia. The big thing to know about Mycoplasma genitalium is that we're really seeing a lot of resistance to Mycoplasma genitalium. We have seen significant azithromycin resistance, upwards of 90%. Doxycycline is largely ineffective. It's sensitive in only 30% of the cases. And a number of studies have shown that moxifloxacin has been the best drug we have, but that resistance is also starting to emerge to moxifloxacin. If you were going to treat this infection with anything, I would definitely use moxifloxacin. So in the US, we are generally testing people that have recurrent urethritis and cervicitis, people that are first treated potentially for gonorrhea, chlamydia, and/or trichomonas, but still have symptoms. That's really who you want to think about Mycoplasma genitalium to test. If you don't have testing available, you may want to consider an empiric course of moxifloxacin. And I do want to highlight moxifloxacin. You know, the other quinolones are not as effective against Mycoplasma genitalium, so you cannot generally substitute ciprofloxacin. You really have to use moxifloxacin. In the US, given the emergent resistance of antibiotics to Mycoplasma genitalium, it's actually being recommended to use doxycycline first, followed by moxifloxacin. And there's data, and this is still a moving target. We're still understanding a lot about this, but there's some data that treating first with doxycycline will reduce the bacterial load of the organism that will allow moxifloxacin to really come in and completely kill off the organism. So there's some data to support that. Again, we're still learning about it. And what I would recommend, just thinking about urethritis, cervicitis, if you don't have access to great testing, or, I would recommend treating for gonorrhea, chlamydia first, of course. If someone has persistent urethritis or cervicitis, you may want to consider a treatment of flagyl, metronidazole. We'll talk about that next for trichomonas. Someone still has symptoms, you may want to consider if you have available moxifloxacin, which will treat Mycoplasma genitalium. I'm going to skip over genital herpes. The only point I'll mention is that serology is not helpful, that we are really recommending here in the US, PCR testing, NAT testing, primarily, secondarily culture of genital lesions to make the diagnosis. The serology, the antibody tests are largely unhelpful, at least for diagnosis. And I think most of us know that acyclovir certainly is a first-line treatment, very effective in suppressing and reducing the number of days of infection. Again, herpes, of course, cannot be cured. A number of people have recurrent episodes. If they do have recurrent episodes, you can consider daily acyclovir for treatment. Finally, I want to end on trichomonas here. In the US, trichomonas, and across the world, it's the most common non-viral STI. So we do know from prevalence studies, it's incredibly common. Similar to mycoplasma, there is an association with some pregnancy outcomes, with some complications, but it's not that strong. The data is not that strong. And for this reason, despite its prevalence, here in the US, we really only recommend screening, and screening meaning testing asymptomatic people, only in HIV positive women, because of the implications of increased risk of HIV transmission. So we don't, in the US, we don't generally do screening for asymptomatic women. If people have symptoms, we definitely test. We do NAT testing. And I think I just wanted to highlight, historically, the testing has been a wet mount, but we know that the wet mount here, if you look, is only about 50% sensitive in this infection. And so here in the US, we've largely moved to NAT, PCR-based testing, which are much sensitive. And the other thing I'll point out is that the treatment recommendations just changed for trichomonas. Mainly, there's been some studies, at least one well-done randomized controlled trial that showed that 7 days of metronidazole is best. Previously, it was a one-time dose of metronidazole, 2 grams PO once, but this has shown to be slightly inferior to metronidazole 500 milligrams twice a day for 7 days. So I think I'll end there, but I'm certainly happy to answer any questions. Thank you so much for your attention.
Thank you very much for an excellent presentation. I think we'll take questions after the next speaker has completed his. Our next speaker is Professor Zafar Hayat. He's currently a professor of internal medicine at Kabir Medical College, Gandahara University, Peshawar, Pakistan. He's a distinguished teacher and an administrator throughout his career. He was awarded by the Commonwealth Medical Trust for his extraordinary contributions in promoting medical ethics. He was also recognized with high honors and awards in patient care and teaching and training of undergraduates and postgraduate medical students. Dr. Hayat will be talking about most common STDs in HIV positive patients in Pakistan. Over to you, sir. Thank you for joining us.
Thank you very much. Thank you very much for having invited me to this August webinar. A talk on the most important global problem, and particularly also relating to our country. And in the most distant parts of our country, people are quite unaware of this problem, and probably due to the dearth of medical facilities in there, and diagnostic facility, patient awareness, education, and lack of advocacy loop. Probably the input from those areas less as compared to the cosmopolitan cities. My task is quite big and time is short, so I will request you, and I will have to run through some of the slides. Most of my slides in the picturesque, and this picturesque memory is very important for physicians and doctors and internists, so that they can look at a patient and they can have pick up a mind that these people should be investigated for. Okay. Um, is a problem.
If you go into the
Can
slide,
you see my slides?
yes, we can. If you just click on the slideshow, yeah, that would help.
Is it all right now?
If you click on the slideshow at the top, where the
Wait.
options are, yeah, just go a little bit up.
Now, is it all right?
That's better, yeah.
You're getting now. Okay.
Yeah.
More than physics check.
Yeah, I can see it.
Camera check करो यार.
Hear you. We can hear you. So if you just continue.
Now, the title is most common STDs in Pakistan, and then you see these two studies that I've just put in forth way back in 2009-11, and the other one also in the 2009. So these are basically telling us that STDs are not very uncommon, but an alarming problem in our country. The data is mostly from the metropolitan cities of Pakistan, but in the far east, far west, far south and north, the problem is more rampant, which has not come to the surface, but we get the patient from there and in our individual practice. The diseases as of now, which we have seen common in Pakistan, are gonorrhea through to syphilis, chlamydia infection, HIV, fungal candidiasis, trichomonas, rare, but still there. Gardnerella vaginalis and human papilloma virus and herpes simplex. This gonorrhea is alarming. Not that much. This alarming. Herpes simplex. But at a BC, yes, this is making a big problem. So my task is in three parts: most common STDs, an HIV positive patient, Pakistan, common treatment use, challenging the management HIV/RT along with STDs treatment. My task has been much eased by the early speaker, thanks to him. So the most common STDs in HIV patient Pakistan, as we have seen from our HIV management and resource centers in KPK, Khyber Pakhtunkhwa, Pakistan, which is my province, rather our province. The authentic data reveal the following most common STDs or STIs which have been associated with HIV, recorded and treated patients. This is important. Gonorrhea, chlamydia infection, syphilis, human papilloma virus, and the two BCY hepatitis, the most common theme. I just go to Google. Much has been talked about it by the earlier speaker. More elaborated than me, probably I would not be that much to cover for as he has. Thank for him. But you can see that gonorrhea is a worldwide disease, like my colleague expressed. Chronically, it's causing purulent infection of the mucous membranes of the genital, and both in female and male, and rectal discharge, vaginal discharge, and these are common form. But one thing I must tell you, our people are very much resistant. Rather, they keep things quiet. It's only the system review which we take in patient of fever or abdominal pain or things like that, or if they've got a monoarthritis or they get a skin rash or something, then they disclose that, of course, they got a discharge, and then we go for further evaluation. So most of the people are keeping it as a stigma and do not reveal because of the frigid society, So we have to take care of that. And the system review must include the genital or the venereal part in questionnaire, discharges and promiscuous sexual activity, extramarital activity, sport, etc. Way of intercourse, MSM is not that uncommon in our situation as well, but it's kept the way, especially the transgenders are being used. So this is the estimation, which I don't want to go into detail. I'll just go a glance feed. Gender-related demographics 1 to 1.4 in male to female. The general symptomatic patient may be there, asymptomatic patient may be there, they may be stealing their symptoms, ectopic pregnancy, infertility. All these patients should be screened for pelvic inflammatory disease, PID. Ultrasound should be done to see, and then one should do all the tests, the chlamydia, the gonorrhea, and syphilis, which can cause, especially the gonorrhea and the chlamydia, which can cause ectopic infertility. These should be tested for that, along with other reasons for infertility. Ectopic pregnancy. Disseminated gonorrhea is not uncommon in our country because we have poor people, and by the time they come to us, they are heavily infected. They come to us with perhaps of uncertain origin. But if you are examining them according to the norms of medicine, take a history, physical examination, abdominal tetanus, and then cystostomy about the genital health, and include the in your system the vaginal discharge, the urethral discharge in a male, dyspareunia, previous abortions, the things like that. So that will probably include this patient and dig out into the people. Age-related 2 to 40 in US has been reported, of course, but our people are going a little to the right because those people are sexually active more after 30s and to your 40s, 50s. And they're coming with this gonorrhea and these STDs, STIs. And young people, because there are a lot of religious frigidity and not much mingling of the male and female genders, so the infection is less often that, except in the college and university students, which I've seen. Race-related, again, poor socioeconomic part of the country is more involved. In Pakistan, because of the lack of education, as you see, dearth of diagnostic and treatment centers, we have to develop an advocacy loop, which should the center is the healthcare providers in the systems and the pharmaceuticals, and is surrounded by the government, the politicians, the high ups of society, the mosques people, the Maulana Sahab, jo hum kehte hain unko, and the college and the students of the high schools and the teachers, and they should make people aware. This is very important. Awareness should not be a scare, but it should be awareness. And then they should educate them on the diseases, and they should educate them on the sexual behavior, social, mental, drug abuse, and all those things which make you prone to this sort of problem. I think we need that to cover it. It is not a job of a single physician or a single institution, private or public, to it governmental and national level task forces, which should have advocacy loops at the nation level, provincial level, and then the divisional districts, and then the tehsil level, and should go to the ground level. It should be from top to bottom and bottom to top approach, which is internationally done. Next, I come to the practice essentials, how they present the patients are very much clear. Discharges, which I've given you pictures, and I will have to go through it, run it through it, because I have less time. So the major genital symptoms of gonorrhea, vaginal discharge, dysuria in the female gender, and dyspareunia And my lord, if the patient come to you, you have to take cysteine. PID is here. All people, all women with lower abdominal pain, back pain, pulmonary discharge, rectal discharge, maybe of some system review. The patient not telling you because of shyness or keeping it hidden. Cervical morsel tenderness, the next tenderness by gynecologist must be done. And if there's tenderness at a mass on one side, the next ultrasound should be done and find out that it's pelvic inflammatory disease. Intermenstrual bleeding, fever, chills, nausea, vomiting may point towards more disseminated retro back toward the abdomen and causing peritonitis and perihepatitis, which you see later, the female. In the male, urethritis, acute appendicitis, acute epididymitis, urethritis, urethral stricture, and prostatitis. I have seen all these complications with these diseases. Acute, when they come, they don't tell you, they hide it until they go to a neurologist, where they are taken up and usually refer them for smears for diplococci. And you know, I hope you can see the picture. This is the neonatorium, the baby born 30 days later may develop neonatorium, ophthalmic neonatorium, which is very serious situation for the baby, and it may be from infected mother gonococcus or chlamydia. The undisseminated gonococcus infection is gonococemia. Clinical features include early bacteremia. This is called the dermatitis, arthritis syndrome, tenosynovitis, arthritis of one or two joints. Usually monoarthritis is very hot and tender, and the patient become disabled if the knee joints are mostly involved and they are bed-bound or wheelchair-bound. Localized infection, anemia can occur, and purulent arthritis can occur, which has to be drained and sent for culture. At the same time, you have to do all the tests for other osteomyelitis, meningitis, endocarditis, respiratory distress syndrome, and sometimes it resembles staphylococcal shock syndrome. So all the people who come to with septicemia and the female gender and have shock and something, one has to do blood cultures, which should differentiate and genital examination and tests. First Kurt syndrome is something which is a retrograde spread of the pelvic infection to fallopian tubes, and it goes to the abdomen, peritonitis, and the perihepatitis potential space due to vacuum sucks it and causes fibrinous inflammation, which teeter the liver to the intestine. And when you open it surgically, like violin wires, they are just looking. I'll show you the picture. These sort of leucemia are more common in people that got complement deficiency, HIV disease, or systemic lupus erythematosus because immunodeficient. Gonococcus subtypes are there, which are very important, and they carry characteristic surface protein. The surface proteins are important because they are depending on the virulence. Some are very virulent, others are less virulent. The very virulent will cause the disease in the serious disease in the immunocompetent people. Less virulent can cause similarly serious illnesses in the immunodeficient patients like HIV and other people who are cytotoxic or steroid. So susceptibility to infection is because of these subproteins. Again, antibiotic resistance, which is very important, growing is by the X6 plasmid, which the surface protein bacteria carry, and they transfer to one another. And this can cause spread of the resistant strains in our society, and whatever drug we are using, the patient may not become less susceptible to these antibiotics and may not make a problem. So one has to keep in mind this. Therefore, inadvertent use of antibiotics is not very much a wise job. We should, try to discourage it, and it should be given according to the.
I'm sorry to interrupt, Professor Zafar, but can you wrap it up in 3 minutes, please? I think the duration is 15 minutes. Thank you.
Fluoroquinolone resistance is again reported. These are the diagnostic blood cultures, glucocai in the smears. Others are DNA and PCR and LCR tests. I have a lot of tasks yet, but anyway, disseminated gonococcal infection are again by blood cultures and septic joint aspiration and CT scans, other for the abdominal. Medical therapy is already described. I think you know about the ceftriaxone by my previous colleague. Similarly, local genital infection, disseminated infections are very clear, already described. The United Thelma needs lesser doses. Chlamydia, already well described. I'll just show you the pictures. You can see this is more common in the female because of the cervical ectopy of columnar to squamous epithelium, which make the ladies more prone to infection with chlamydia because the squamous epithelium is resistant. These are chlamydia trachomatis. The most common again because genital chlamydia are TK and the chlamydial trachomatis L13, it causes the lymph delirium. So I go to the cycle. The cycle are very much clear. Elementary bodies and the replicate reticulate bodies enters the cell, make a vacuole, binary fission, burst out of the cells and spread to other places. See, these are clinical features well described by my colleague. And men, women, both can be the woman can have extra genital infection, the man both, but the lady can have the same pelvic inflammatory disease and all complications. These are the chlamydial infection, the female, the cervix, the conjunctivitis, and complications in men. Again, you can see this is the first Hug syndrome, which is again complication of chlamydia as well. This is the tubo-ovarian swelling, and this is the succinate peritonitis. This is the Rita syndrome, like keratoderma breragica caused by chlamydial infection and monoarthritis, digital gangrenes. Investigations are again well described by my colleague. And MSM men and commercial sex workers, NET tests are very important. It's a nucleic acid replication test, which are very much recommended. First line, second line, third line drugs are there already described. And then go to chlamydial PID, again described well, ceftriaxone, epididymitis, and then lymphodenema venereum. HIV infected patients are more prone to, and they should be screened by the chlamydia L13 is causing it. Incidence is more in these areas, and you can see the age, gender relations, more common male and female. Again, the spread to the local lymph nodes, perilymphadenitis, thrombolymphodenitis, lymphangitis, and then abscesses tabulated, and this can rupture and heal by fibrosis and can give chronic edema and disfiguration. These are the transient and vaginitis proctitis, the primary stage. The second stage, anorectal, is more common in male to male sex partners. These are the various the lobular lymph node, the ulcer scarring, lymph node baboons, and again, very small buboes, the lymph node, which may rupture abscess and can fistulas and strictures, rectal abscesses, and all these can be made. So I would request my surgeon colleagues and gynecologist colleagues that if they see a rectal perianal fistula or rectovaginal fistula, they should please investigate them for these organisms. Surgical management is one, but this recurs if you don't treat them. Investigation on NATs again, very important. Nucleic acid amplification test is very important for it. Go through it. This first line is doxycycline. I will describe syphilis, spirochete, sexual contact, vertical transmission from infected mother, blood transfusion rare, contaminated transneedle very rare. But in mainline user and HIV patient is common. Early is primary, secondary, early latent, late is latent, tertiary, syphilis, cardiovascular, congenital is here. Then we go to the Shankar is usually appear 3 weeks after exposure and it's 90 days incubation, be painless, non-purulent. Also, it should be differentiated from other ulcers because all the STDs are causing ulceration, but those are purulent. And this is non-purulent, and you can the lymphadenopathy is here, so it can come in lymphogranulovenereum, but those are scarring, and this will never scar. These don't rupture. This is the glanspinous chancre. This is the chancre on the urethral orifice. Look at this, and then the scrotal also. This is again the pubic skin ulcer shaft. This is cervix in the female. This is again perianal and vulval with condylomata. So these you should, if a gynecologist remember this and she looks at the lady and find this, she should straight away go for STDs testing for all women like this. These were the kissing ulcers of the, vulva, the perirectal, the lip, the chin, the finger. It doesn't spare any place. My God. Chancre, if untreated, has spontaneous, within 2 to 4 weeks history. Spontaneously is very dangerous, this part, you remember. There will be an atrophic scar, which may be memory to the previous infection. Lymphadenopathy resolves, and 50% of the patient go to secondary syphilis, 50% untreated interlatent phase of syphilis. And look at it, like my colleague said, rash, and all those things will be with the secondary, but let us see what happens to the lymph node retroauricular. It's the rash. The rash is different. Don't say it is measles, please. Every rash should be taken as STD until proved otherwise. Look at this papular rash. This is psoriatic type of rash. People will take it for psoriasis. You have to check that. This is the lichenite psoriasis like. These are sort of palms and soles are usually taken as fixed drug eruption by the dermatologist and many radiologists. I'm sorry to say this, but I have seen it. It should be always tested for syphilis. These are the people who will have HIV, and if they got a lot of ulcers, like I showed you, they have HIV, and those are HIV patients. This is the HIV patient. Look at it. This is the moth-eaten alopecia. My God. This is the eye. Auditory, my colleague described, and I remember a case with Albert Robertson pupil and deafness, and we took that. It may not be vertigo, it may not be lateral medullary syndrome, but later on we found it was due to syphilis.
Dr. Zafar, please
I'm trying my level
slides.
best. Okay. This is
Thank
the treatment has already been described by my colleague, and these are all, this is the neonatal, this is the shortcut. The other one is the aneurysm of the aorta. This is the severed tibia and the frontal bossing. You can see severed tibia. HSST. Specific tests all have been described by colleague, but one thing which I would add is that these tests were antibody related, and they may become negative in immunodeficient patient, and the patient may be missed by these tests. Therefore, one has to keep it wide to do other tests. These are the treatments. Genital herpes already described by my colleague, and this is the genital wars, papillomavirus, herpes simplex. Now BC or elite with the B and C, the co-infection hepatitis. B and C is very common in Pakistan, and this study was done in Khyber Pakhtunkhwa, and you can see that study highlighted co-infection, 4/5 for HBV, 1/5 for HCV. Hepatitis B virus is a APPNA-MERIT, 100 times more infective than HIV. You can see the electron microscope picture. This is central DNA with polymerase enzyme which repair it and other things. This is the cycle. The virus enters to the receptor, and then it unloops, and then the relaxed DNA go and just change it to cccDNA. which is the very important part, covalently closed circular DNA, which is for lifetime, like an HIV. It fixes in your genome. Then it makes templates of all the parts of the DNA, RNA, and then it goes into the cytoplasm, rough endosome reticulum. Rough endoplasmic reticulum, the place where protein synthesis occur and the viral proteins are made, and then they're collected together. Golgi body finishes it and then throw out the Dan particle and infect them.
I'm sorry to intervene, sir. Can we finish it soon so we can move on to the question and answer?
I got a few slides to show because now few slides which are important in the third part. I'll go to that if you can allow me. So I will show those 3 parts. These 3 slides.
Okay.
Just go to the hepatitis B, C, and everything. And I will go to the third part. This hepatitis C again cycle and the phases and infections, investigation. This is the treatment guideline and which drugs we can use in HIV is that we have to be careful because the directly acting drugs are very toxic to the liver. So the pegylated interferon, ribavirin has to be used, but ribavirin also has to be taken care of because with the nucleoside reverse transcriptase inhibitor, it can cause lactic acidosis, and that is a very serious situation. This is the co-infection treatment of hepatitis C, human deficiency virus is this. Again, it is, I can't go to the detail of this. I have made a cycle for you. Co-infection with the this part is challenges managing ART along with STDs is important. Co-infection with syphilis, gonorrhea, chlamydia. These are a few lines which I told. Clinical manifestation of early syphilis missed by HIV status. If the patient got a latent syphilis and the patient get HIV, this latent syphilis, which is asymptomatic, will suddenly develop ulcers and lymph nodes. The other thing is the routine screening test found effective and detected. This is another very important syphilis. The burden of new syphilis in London has really increased in the MSM people, and therefore it's important that we should screen for syphilis because there is asymptomatic syphilis. This is again very important. Syphilis infection was associated with decrease in the CD4 cells and high viral load in this study. These are the secondary syphilis, again increases cases among HIV infected person who are particularly concerned individuals at risk. These will progress to the syphilis may progress in HIV patients who are latent or who are otherwise having little sort of symptoms. So therefore, we must HIV infected individual will lose fluorescent antibody tests because of the inability of the antibody to develop, and these people will be one which will be missed, and they will spread the disease to other people. So therefore, it should be kept in mind that HIV is a CD4 cell depletion disease, and immunodeficiency antibodies may be these are the cerebrospinal fluid.
Sorry, Dr. Zafar, we have to.
This is the last one. This is the last one. This is important. A persistence of treponema in the fluid, CSF fluid has been seen in patients, and in these patients, if you do the CSF and the CSF shows pleocytosis, and VDRL test should be done on it, and they should be treated as neurosyphilis patient. These are the patients who might have been treated before, they don't remember, or they steal the history from you, or they may have no neurological symptom, but simple deafness or cranial involvement. And this, when they get HIV, their symptoms exacerbate, and therefore we should be kept in mind and treated. There were many, many other things, but I'm sorry you don't have time. So anyway, these are all things for me. Thank you very much.
Thank you very much for a comprehensive presentation, Professor Zafar. We've got some questions in the Q&A box, and I'll start. Is there any way to reduce reluctancy when asking questions about STI in Pakistan? Probably it's best if we direct this question to Professor Zafar. When taking the
I think having been in clinical practice for a long time, first in the public care hospitals in Khyber Teaching Hospital, Khyber Medical College, I retired as the head of the Department of Medicine. And at that time, we used to treat all the infections. The senior professors, dermatologists, and virologists were not there. We have seen that time. Now, mashallah, there is a lot of specialty showing. But people are hiding, even now. There is a stigma of sexually transmitted disease. People have discharge. They know they have got this infection because they know they have got extramarital contact, especially in the high elite people, and they will go here and there and try to. The far distant people from metropolitan cities, south and north and east, west are having lack of awareness, but do have behavioral disease, behavioral sexual disorders. And they do have, partners, and they do have multiple extramarital relations, and they get infections, but they don't know what to do. And they go to local hakim and local to quacks who treat them with recipes and emollients and whatever. But, in the end, they come to hospitals. So when we go to the hospital, so if you have in mind the picturesque scenarios and the pictures of the diseases in mind, which I had pasted in my ward, so then you have to know. In our MRCP exam, why the picture quiz was there? Because it to give you the spot diagnosis, and then you go for and the people cannot see, and that's why there is people who are many people who are stealing it, especially HIV. I tell you, there are a lot of HIV. The studies say HIV is less in Pakistan. I say the first 82 patients I reported in 84.
Yeah.
84, when I was working as a pathologist, lecturing pathology. And I told the government to make our advocacy loop. Told the government to, this is not that we got HIV centers and this and that. You have to have a preventive network, task forces, just like we did it for the corona. Why the corona was controlled in Pakistan so efficiently by our government? Because they consulted us. They made every person inclusive of the program, and that is how the input from here, input from America, input from Britain and Europe, everything, webinars of the Royal Colleges. Then we suggested and we made networks. We made task forces, and that is how it is controlled. So I think the same can be done to this pandemic, which is a very slow, smoldering pandemic. Corona was a pandemic which was killing people, apparently. There was a scare, like a lion coming in a village, and everybody running and hiding and trying to protect or kill the lion. But these sort of pandemics are indolent, occult, hidden, and spreading and destroying our society.
I think we've lost Professor Zafar for a moment. Right. Okay. I think while we are waiting for him to get back, we'll move on to the other question. And I think I'll ask this question from Dr. Chan. It's about congenital syphilis. And it says, what about congenital syphilis STD, suspected babies? Any preventive antibiotics?
So I was looking at this question and the next question, which I think are similar, asking about congenital syphilis, I think in the baby or the mom. So just to clarify, this is one of the most serious complications in syphilis, is congenital syphilis. And so that's why it's really strongly recommended to test all pregnant women for syphilis, and of course to treat them if they are positive. For any babies born to mothers who have had positive results, it's really important to test the baby as well, with the caveat to remember that for the treponemal tests, the TPPA tests, other treponemal tests, is that those may be difficult to interpret, because if a mom is positive, her antibodies will pass through the umbilical cord into the baby, and it may confuse the results. So the diagnosis in a new baby is difficult. You should check non-treponemal titers for sure. And you also need to do a very careful screening of the baby for congenital syphilis. And so this includes looking for hyperbilirubinemia, LFT abnormalities, skin rashes, rhinitis, classic manifestation, etc. So key is you really want to do a very careful physical exam, etc. In the situation where there is an abnormal physical exam, or you also have high non-treponemal titers, high BDRL or RPR titers, or you have a positive dark field test, you do want to treat the baby for either confirmed or highly probable congenital syphilis. But there's no prevention of it. The prevention is testing the mom and treating the mom. That's how you prevent it as soon as possible from transmitting to the unborn baby.
All right, great. Thank you very much. I don't think we've got any other questions left. You've answered, obviously, the other one. Sorry, just one has come up. Can infection spread to kidney or other organs from outer genitalia? How much chances for it? They haven't specified any infection, so I'm assuming it's any of the STDs.
Yeah, I can answer that. So we do occasionally. So for gonorrhea and chlamydia, there is you can get ascending disease, right? So that's essentially what pelvic inflammatory disease is. There's also a syndrome known as Fitzhugh-Curtis syndrome. And that's where chlamydia and gonorrhea actually infect the capsule around the liver. So it's not directly infecting the hepatocytes per se, but it's infecting, it's going around to the capsule. And I've had a couple patients with this, and they present with right upper quadrant pain. So especially in young women who come in who have right upper quadrant pain, of course you should check LFTs, but in the back of your mind, you may also want to check a urine gonorrhea chlamydia test, because it could be one of this more uncommon manifestations. The other thing I'll end with is just syphilis, especially. Syphilis has been described similar to TB as a masquerader, right, of many different clinical syndromes. So syphilis could affect kidneys for sure. You could certainly get gumas or other manifestations. So on a rare cause, you could occasionally see kidney or other manifestations of syphilis in the GI tract.
Great, thank you. I think the next question would be from Professor Zafar. How much congenital rubella prevalence is in Pakistan or South Asia? Professor Zafar, if you can hear me, would you be able to answer the question?
Hello?
Hello, can you hear me, sir?
Can you hear me?
Yes, I can hear you. Yeah. Can I just repeat the question? How much congenital rubella prevalence is in Pakistan or South Asia?
So far as I can infer from my practice and the study, the rubella is quite common in Pakistan and in South Asia, because you see that every now and then we get, babies born with congenital deformities, which is reminiscent of the lady having had rubella, and those typical abnormalities which are associated with the congenital rubella. And at the same time, there are studies to this effect, which are done by our gynecologists, also done by our epidemiologists, and myself. And the vaccination is quite commonly given to the women in the big cities. But if you go to the villages and the far villages, then the vaccination program is probably very poor. And that is the reason that people the women with those are coming with rubella, and mostly they lose abortion, they lose the babies, abortion, and that's how when we screen them. So cases as such in adults, rubella in female are not that much coming to our practice. They go mostly to the skin specialist, dermatologists. I don't know how do they deal them, but they should have more idea about the adult rubella coming as clinical features in infected patient. But what we have been getting are the congenital deformities, which then calls the gynecologist, and we go and we check the patient and the pediatrician.
Yeah, I think in the absence of a disease registry, our data is patchy. Yes, as you said, it's quite common, but we do not have figures to say. Okay, there's another question. Can it be possible to have COVID vaccine can be given to HIV patients safely? CD count less than 100. Any of the speakers can answer this question.
I think are the HIV patients who have got who have been ART, antiretroviral therapy, heart therapy, and they're symptom free, and their CD4 cells are high, and they should be given the vaccine. But if the CD4 cells are low and the patients are still symptomatic or incompetent, so I think there will be it should be controversial that if you give a vaccine, it will not arouse the desired antibody response and protective response, protective antibodies. Similarly, the case like hepatitis C, we don't treat them serious patients first when they are having high RNAs and this PCR, but we first treat the antiretroviral. We treat the HIV with the antiretroviral drugs to increase the immunity, because if you give pegylated interferon to these people, already their CD4 cells are low and it's further breaking down. Platelets will come down, psychological and other side effects of pegylated interferon are there, and the directly acting drugs in hepatitis C are very toxic to the liver. So you can't give them in such situation where there's a dual. But usually the HIV prognosis is worsened by associated co-infection with the hepatitis C because the liver disease progresses very rapidly. But if you treat the HIV and then you secondly treat the hepatitis C, then the people get desired response. Now here I won't probably recommend to people who got CD4 cells less than 100 or 100. I think they should have more social distancing, self-protection, and
okay.
Yes.
Okay, there's another question, and probably you would be able to answer it because it's about Pakistan. Is HIV testing routine for non-HIV STIs in Pakistan? Those who present with non-HIV STIs.
I think, I believe, but I believe that most of the tertiary care hospital and the district care hospitals, and they are doing routine tests for hepatitis B, C, HIV. Yes.
Dr. Hina, may I request the answer from Dr. Phil Chan about that COVID question, COVID vaccine question?
All
so
right.
maybe, yeah.
Thank you, Dr. Jilani. My opinion would be that I would personally absolutely give the COVID vaccine to people with HIV. We avoid live vaccines in people people with HIV who have CD4 counts less than 200. I think that's the key point. Is for live vaccines you want to generally avoid in people with HIV who are less than 200. However, the COVID vaccines are not live vaccines. They're mRNA vaccines or a vector protein vaccine. So you can safely give them. And in fact, I would advocate probably that you should give them, especially if their CD4 count is less than 200, because the risk of COVID, if you are HIV positive and immunocompromised, is very high. And so the risk of giving a vaccine that is not a live vaccine the benefits would probably usually outweigh the risk. So I would advocate for it. Thank you.
Okay, thank you for adding that. How much time it takes from primary to tertiary syphilis symptoms to appear? Dr. Chan, if you can answer that question, please.
Yeah, so it's a good question. In general, the stages of syphilis, primary and secondary, it can take up to 3 months, up to 90 days for that primary stage to appear. Usually it's much shorter than that, but it can occur up to 90 days. And then a lot of times there's an overlap. Usually primary syphilis is the first described stage, and then leading to secondary stage. Again, the primary stage, right, is usually a painless chancre ulcer. But a lot of times people don't have anything because that chancre is inside either a mouth, it's hidden, it's inside the rectum, inside the vagina. So a lot of times that painless chancre is missed, and there's overlap between that primary and secondary. If you did nothing, of course, that painless chancre would heal in a couple weeks and go away. And likewise, if someone had the rash of secondary syphilis, that would also resolve over a week or two and go away.
Okay, great. For Dr. Chan, it says COVID-19 vaccine can be given to pregnant females.
Yep, I would. So in the United States, we have 3 vaccines authorized: the Pfizer, Moderna, and Johnson & Johnson. And there's good data on all 3 of those vaccines. I want to be careful about commenting on other vaccines, but at least for those vaccines, it's strongly encouraged by the CDC. And there's been a lot of data that has come out over the last couple months that have showed that those vaccines are very safe during pregnancy.
I think even our Special Assistant to Prime Minister, Dr. Faisal Sultan, he's an infectious diseases consultant. He tweeted us some time ago that even those available within Pakistan are safe, and he encouraged women who are pregnant to have the vaccine. Okay, thank you. The next question.
Just a comment. So the Chinese vaccines which are available in Pakistan, 2 of them are killed vaccines, inactivated. So inactivated vaccines are also traditionally known to be safe in pregnancy. So they are okay. And then we have CanSino, for which there's ample safety data available. So all vaccines which are available, even AstraZeneca, which is in use in Pakistan, you have to weigh risk versus benefit. But the others, or the rest of the vaccines which are widely used, are all safe in pregnancy.
Okay, thank you. We've got 2 questions. Hepatitis B baby born, can immunoglobulins be given to baby which mother also have HIV in the past? So mother has HIV and baby born is hepatitis B positive. Obviously the mother is positive as well. So can the immunoglobulins be given to the baby? That's the question. Any of the speakers can answer it.
So I spend most of my time treating adults, so I apologize. I actually don't know the answer to this question.
Okay.
I may be able to comment here. So the standard regimen for a baby who's born to a mother with active hepatitis B infection is immunoglobulin at birth, and followed by vaccination, HBV vaccination. So it is absolutely essential to screen the mother if she's not screened before, but she should be screened in pregnancy. So both HIV and hepatitis B tests and a VDRL should be offered to all pregnant women, so that if she has these infections, it's screened and the baby is treated appropriately, because baby can be protected if the diagnosis is known before birth.
Okay, great. And Dr. Bushra, I think if you would be able to answer this question as well. COVID-19 vaccines for babies of 6 months of age. And the other question is related, which trimester in pregnancy can a COVID-19 vaccine be given? Can it be given at any time? And is it safe for babies 6 months?
Yes, all currently available COVID vaccines are quite safe in pregnancy, and they are safe in all trimesters of pregnancy. One reason for saying this is that COVID infection can have serious consequences for pregnant women. So the risk of infection is much more than any perceived risk of vaccine, and the vaccines have been shown to be safe in pregnancy. So they can be given in any trimester. The youngest age at which vaccines have been seen in clinical trials is 3 years of age. So I don't think there is any COVID vaccine which has been tested on babies who are younger than 3 years of age, or at 6 months.
Great. I know our time is almost up, so I'll just take one more question. What about hepatitis C positive mother and neonate? How should we proceed with their treatment?
Hello?
Yes, Professor Zafar, would you be able?
Would you repeat the question, please?
Okay. What about hepatitis C positive mother and newborn? How should we proceed with their treatment?
A newborn.
Yes.
Newborn baby and the mother.
Yes.
So we have to test the baby for anti-HIV antibodies. Initially, it cannot pass transplacentally. It will be only passed when the baby is born, and the maternal blood is sucked by the baby blood, and it will take time for the anti-HIV to become positive in a baby. But the mother has to be taken into this, and we have to do our anti-HIV, we have to do our LFTs, we have to do our ultrasound, and we have to do our quantitative PCR for HIV RNA load and genotyping. And if the patient is otherwise health-wise well, and the SGPT ALTs are not very high, and the patient, you can keep her for a couple of months before you start the treatment, counseling with the husband and the wife both, whether they would like to, and explaining them the side effects of the drugs also. The rapidly acting drugs are very safe now for non-pregnant women. And, if the patient has a very high PCR, LFTs are raised, because usually pregnancy has a bad effect on the liver. So I think she should be started on the drugs. Peglet interferon should not be given to pregnant women. It can be, previously it was given to postnatal ladies, but now that is just a history. We have to think about the safe anti-viral drug which are direct acting, the DOS therapy. The baby has to be followed up. The baby will not have any problem because they have very immature immune systems, and they would not cause much problem. But even if the baby become anti-HIV positive, then we have to follow up. And I would like to consult an neonatologist and a pediatrician to comment on such a situation that baby actually positive after 5-6 months, and ALT is normal and other things. Usually the baby do not suffer much, but the mother can postnatally the liver disease may flare up, and therefore she should be treated by doing other tests.
Okay, I'll just take this one last question. Can COVID-19 vaccine antibodies transferred to baby from mother through the placenta? That would be our last question.
I would imagine that they can. Would love to hear the other panelists, but I would expect that they can. And we do know, of course, that children are really generally much less risk for COVID.
Great, thank you. I don't see any more questions in the Q&A box. So thank you very much to our speakers who've taken the time out today, and all the panelists and the audience. So thank you and goodbye. Allah Hafiz.
Thank you, everyone, and special thanks to Dr. Hina Javed for moderating the session, and thanks Dr. Phil Chan and Dr. Zafar Hayat and Dr. Busha Junaid. Thank you very much.
Thank you all.
Thank you.
Thank you. Bye-bye.